them to get blood. Okay? It's what's called a perfusion pressure. All of them require a certain pressure. Okay? For your coronary arteries themselves, okay, require a mean arterial pressure of about 70 in order to be able to get good blood flow. If you get a mean arterial pressure in the 50s, the coronary arteries aren't getting filled very well. And that also kind of stands true to the kidneys and to the brain and all of those things. They require a driving pressure. But I'm going to use the heart, since that's what we're talking about, in what we call this perfusion pressure. Okay? So perfusion pressure is the pressure required to perfuse the organ. All right? And for the heart, it's typically about 70. We do a pretty good job of going this, right? Blood pressure is 120 over 80. Right? Well, what's that mean? How do I know with a blood pressure of 120 over 80, am I meeting a perfusion pressure of 70? How do I know? Any thoughts?
Add those two together and divide by 2.
Pretty close. Now I'm going to show you the mathematical equation. This is one way to do it, and then I'll tell you the shortcut to it. All right? So let me ask you this. Why do we say hypotension is a blood pressure less than 90 over 60? Where does that come from?
So it's just the other side of the equation saying that you're not meeting your minimum MAP for perfusion.
Okay. What if I tell you that a blood pressure of 90 over 60 equals a mean arterial pressure of 70? Okay. See that? So with a blood pressure of 90 over 60, I have a map of 70. A mean arterial pressure of 70. Which means if I know at a mean arterial pressure of 70, I'm right on the border of good coronary perfusion. If it dips lower, then I have to question whether my coronary arteries are getting filled very well. Okay? All right, so how did I come up with that 90 over 60? Okay? It was simply this. So I did 90 over 60, okay? So I did 90 minus 60 divided by 3. Okay? So 90 minus 60 equals what? 30. Divided by 3 equals what? 10. And then I add back in my diastolic pressure. Don't rack your brain with that, okay? Don't, all right? But that's how I get that. Systolic minus diastolic divided by 3 equals 10, and then I add back in my bottom number, and that gives me my mean arterial pressure of 70. Okay? Or the other thing that you can do is you can look at your cardiac monitor. When it takes the blood pressure, if you use a monitor to do that, it will give you a number like this, 90 over 60, and then you'll see something in parentheses. That's your mean arterial pressure. But that's how you can come up with that. All right? Now, can I have a mean arterial pressure of 70 or below with higher numbers than 90 over 60?
Yeah, if the difference between your systolic and whatever, the difference between the two pressures are not very great.
Mm-hmm. Right, exactly. So if my differences between the systolic and the diastolic are varied, then that's going to affect my mean arterial pressure. So my point of bringing mean arterial pressure is that I can have a blood pressure of 162 over whatever, Okay, and if that difference is great, my mean arterial pressure could be less than 70. All right, so we use this 90/60 as being hypotension, when we should really be looking at mean arterial pressure and using that to guide some therapies. Okay, so if I have a mean arterial pressure of 60, okay, I know that's low, right? That mean arterial pressure of 60 is low. So I need to be looking at my patient going, okay, how can I improve that? Can I add some fluid to the container by giving them a fluid bolus? Okay, can I add volume? If it's a trauma patient, then what do they need? They need blood, right? They need blood. So do I get blood going? Okay, see where I'm going with that? Or if it's not a volume problem and I think it's a pump problem, then I can affect change with the pump by giving them some other medications. All right, so I'm guiding my therapy based off of really what that mean arterial pressure is to protect the organs itself. And so that's where that comes from, and you're going to see a lot more, I think, as we see changes in the curriculum. I think we're going to be focusing more on mean arterial pressure than we are on systolic and diastolic blood pressure, because it's much more of a relevant. I want to know what the resting pressure is, because that's what's going to be critical to my perfusion pressure. Okay? All right. All right, we talked about blood flow, we know that. So just again to reiterate where we are, this kind of shows a broader picture of the organs and the organ systems in our container and circulatory system. And so again, we have our left side of the heart, which is arterial, okay, higher pressure, as opposed to the right side of the heart, which is venous pressure. And then in between these, we actually have our organs. So we have our brain, we have our lungs, we have our liver and our kidneys, okay? And that smaller network is where that exchange occurs, okay? So again, coming back to our CHF, congestive heart failure discussion earlier this morning, if fluid is backing up, well, guess where it's backing up? It's backing up this way, fluid's going this way, they meet and they squeeze water and red blood cells out, okay? If I'm backing up here, guess what? It backs up here, backs up into the resistance, my liver gets swollen, okay? And it squeezes out. All right? Okay, the next thing we want to talk about is what's called preload, afterload, and then cardiac output. And that's going to take us up to lunch, okay? Preload is the initial stretching of cardiac myocytes prior to left-sided contraction. Preload is also known as available volume or volume, okay? Afterload is resistance. Blood is driven out of the heart against systemic arteries, so resistance. So preload is volume pressure, if you will, and then afterload is the resistance. So let's go back to this one, okay? So preload, I have to have an adequate volume in order to have blood flow coming into the right side of the heart. Okay? So, and then afterload is I have to have the resistance in order to move blood out of the heart. Okay? So I have to have those. I have to have preload and resistance. Okay? So let's talk about a term called cardiac output, and we'll come back to this preload resistance thing here. Okay? So what does cardiac output mean? What's the definition of cardiac output? What's your book say?
The amount of blood that is pumped out by either ventricle.
Okay? The amount of blood pumped out by each ventricle. So cardiac output. Okay? Cardiac output is dependent upon what? What two things?
Stroke volume times heart rate.
Very good. So heart rate, the amount of contractions in a minute, times my stroke volume. What's the definition of stroke volume?
The amount of blood pumped out by either single contraction.
in a single contraction. Okay? So cardiac output is over a minute. Stroke volume is one single contraction. Okay? All right. Stroke volume is dependent upon three things. What are those three things?
Preload,
Okay?
afterload,
Preload, afterload, okay, and
Ejection pressure.
contractility, okay, contractility, the ability of the heart to be able to contract well. Okay, so preload, we talk about volume pressure. Afterload, we're talking about resistance. And then contractility, we're talking about performance. Okay, so these three things. So I have to have an available volume and pressure coming into the heart. I have to have a resistance to pump against. And I have to have a healthy pump in order to push blood out of the heart in one single contraction, which is stroke volume. See the relationship? I have to have the fluid, I have to have the volume, I have to have the pressures, because it's a pressure system, and then I have to have a good pump to be able to do it. Okay? These two are related, and I want you to think of a teeter-totter. On one side of the teeter-totter, I have heart rate. On the other side, I have stroke volume. Okay, so I'm going to go in the other room, and I'm going to clone myself. Okay, simple enough, right? I'm going to come back in, and the difference between myself and my clone is that my clone is a marathon runner. My clone likes to run, runs every day, 5, 7, 10 miles, all the time. Whereas I myself, I don't like to run. So I don't do a lot of exercise. We're the same size, same BMIs, everything is identically the same, except for that one little difference. So if I were to measure the cardiac output, who has the better cardiac output?
The marathon run.
Okay. Marathon runner? What say you, Mr. Spencer? You're awful quiet back here today, and I know that's unlike you. Think the marathon runner?
Probably pretty close to the exact same.
Okay. So I have a marathon runner and I have a same. What do you think? What if I were to say the cardiac output is the same? But how we achieve the same cardiac output is different. See? The marathon runner, what will the heart rate be?
Lower.
The heart rate's going to be slower, right? Why is his heart rate slower?
Because the container is bigger, basically.
Well, not the container.
The vessels, like
What's different between the marathon runner and the stroke volume side? These three things.
it's not pushing against as much pressure. You know what I mean? Like,
Okay, so the blood pressure is going to be a little bit lower, but that's not quite where I'm getting at.
the strength of the contractility, just strong.
Contractility. So the marathon runner has the better, healthier ventricles, the bigger snap, the better snap, okay? So where I lack in contractility, his stroke volume is up because of a better performing heart, a higher performing heart. That's why his heart rate is 40. Okay? So his heart has to work less because his heart is exercised better in order to get a good cardiac output. Now what about me? In comparison to the marathon runner, We know the cardiac output's essentially the same. However, what is my heart rate?
Have to be higher.
Higher.
Yeah, my heart rate is going to be higher because, what about my stroke volume?
It's going to be lower
Why is my stroke volume lower?
because your contractility is less.
My contractility, my contractile force is less in comparison to the other. Do you see the relationship? Okay. So let's take a patient who, and cardiac output's critical. I mean, cardiac output is critical because you got to have organ perfusion and all that other stuff. We already know that. Cardiac output, mean arterial pressure, all that. You're responding to a residence of a 60-year-old woman who's had fever, vomiting, and diarrhea for the last 3 days. Okay? You get on scene, you get a set of vital signs, her blood pressure is normal, but her heart rate is 110. Why is her heart rate 110? It's got to come back to this side. Do I have a contractile force issue? No, not per se, right? But do I have a preload issue?
Yes.
Okay, why is my preload down?
From the dehydration, fluids loss.
Yeah, the fluids loss. We lose so much in diarrhea and vomiting and fever that really this patient's significantly dehydrated. So my available volume is down. Okay, my volume is down, all right? So that makes my heart rate go up. So of this same patient, to maintain a cardiac output, so this same patient, I start an IV and I give her a liter of fluid to increase my preload. As I'm increasing my preload, what should I see the heart rate do?
Slow.
The heart rate should come down, right? My heart rate should come down as I'm giving this fluid. So do you see the relationship between the two? All right? I've got a trauma patient, and they've got a very tender belly, and I've got some bruising. So I suspect what? Internal bleeding? Okay? And so as I'm assessing their vitals, their blood pressure's fine, but their heart rate's 118. Why is their heart rate 118?
Volume.
Okay?
Volume.
So volume. So maybe my preload volume is down because of what? Loss of?
Fluid or blood.
Lots of blood. Loss of blood. Okay? Now as they continue to bleed out, I'm going to start getting my resistance side too, right? Because I'm taking fluid out. Okay? So, but let's just say I stop the bleeding as much as I can, or I get them to the trauma center as quick as I can. They get right into surgery, but in the emergency room, they're getting blood, which is what we want to give the patient. Not a lot of fluids, but blood. So as we're giving blood, what are we improving?
Pressure, the volume.
Yeah, you're actually kind of improving both of these. We're improving that preload volume, and we're going to improve resistance because we're adding volume to the container. And what should my heart rate do?
Come down.
My heart rate should come down. Now, one more thing I want you to think about. One more case that I want you to think about when it comes to the administration of nitrates. Nitroglycerin is the most potent arterial and venous vasodilator that's out there. If you want to dilate the container, you give them nitroglycerin. Okay? Very potent. So what it does is when I give nitroglycerin sublingually, transdermally, IV, whatever, it takes these containers and dilates them. Boom and boom. Okay? Now the arterial side does a pretty good job because it says, you know what, I need a pressure, so it squeezes down. Okay? Because it responds to local needs. The venous side doesn't. So the venous side stays a little bit dilated. The arterial side can kind of constrict out. Okay? What does that do to my preload pressures? It decreases them. Okay? So you're evaluating a 50-year-old male patient that you do a 12 lead on, and Although you haven't learned this yet, he's having a big anterior lateral wall MI. So a big portion of his left ventricle. He's having a big, big MI. Okay? And so we're evaluating him. We do is check his vitals, his blood pressure's fine. Okay? And but yet his heart rate is 118. Why is his heart rate 118? And we're going to say his blood pressure is 108 over 70. 108 over 78.
As his contractility is low, he can't, or because the muscles are dying.
Did we all agree with that? Of the stroke volume, because when our heart rate's high, we need to look and go, what's going on over here? Would we all agree that an MI is a pump performance problem? Okay? And so now I'm impacting my force of contraction or contractility. Right? But could it be also that he's having 20 out of 20 pain and he's really hurting and all that stuff? Could that be a pain response?
Yeah.
It could. Okay, so we're not 100% sure, but it could be. So what we do is we give him lots of morphine. Make him feel good. Okay? Or fentanyl, whatever it is, to try and bring that pain down. Okay? But the other thing that we do is we decide, hey, we're going to go ahead and give him some nitroglycerin, right? Because it's in our order set. We can do that, all right? And so what we know that it's the most potent arterial and venous vasodilator. So I give him nitroglycerin. Dilates that the venous side. So now what have I impacted over here?
Preload.
Preload. So by giving him that shot of nitroglycerin, I've taken that venous side and I've vasodilated it. So now also, what have I potentially impacted?
The contractility.
I've impacted preload, contractility. Now my heart rate goes to 128. All right? And now I see changes in their blood pressure or whatever. Okay? So you see that how that's relationship. So don't always be so quick to, okay, we're going to give them an IV. I absolutely hate giving nitro to somebody without an IV. Number one, nitroglycerin has not shown to improve outcomes in patients with AMI. It hasn't. If you look at cardiovascular consultants at St. Luke's, that big deal, that big group, they don't push nitroglycerin.
So
They give them morphine, they get them into the cath lab, or they get that artery opened up.
So is it more of why we push nitro? Is it just buying time? It's not really helping the outcome at all?
Well, in theory, what you're trying to do is you're trying to decrease the workload. So if I dilate, that improves the workload of the heart, but also the coronary arteries. If I can dilate the coronary arteries, I get more blood flow to the heart.
But eventually it's gonna wear off.
Well, and that's why you give repeat doses of them. Okay, or they get an IV infusion. Okay? So just don't be so quick with giving the nitrates and stuff without appreciating looking at the patient and going, what am I seeing with the vitals? See, my blood pressure is normal all the time. Okay, my blood pressure is normal. It's heart rate. Heart rate is relational to cardiac output. And why is my heart rate what it is? What am I not seeing here that if I do an action, is it going to further impact that?
I was going to say, would you want to take the risk? Say you know that's a situation that could occur, you can increase the heart rate without really benefiting the patient. But wouldn't you want to take the risk if, in case you give them that nitro, increases the contractility by opening up that coronary?
Well, the nitro is not going to improve contractility.
Well, if that blood starts reaching it, or because they having a major MI, like it's already kaput.
Well, it's not kaput, but it's not performing well because, again, in order for it to function well, and this will be more when we start talking about how the cells pump, how those myocytes pump. So all that nitrates are going to do in theory is improve oxygenation to those areas. But again, it's in theory, and really no outcome data to really support to say, yes, this is whatever. So contractility is going to be improved by opening up the artery, getting blood flow reestablished, and letting the heart heal. That's what's going to do it. So with nitrates, you're kind of just trying to buy time. But again, with nitrates, would we all agree that blood pressure is pretty important? okay, especially when we know what's required to feed the coronary arteries. And so if I give nitrates thinking I'm going to help, but I drop the mean arterial pressure, now I'm actually not helping things. I'm hurting things. Does that make sense?
Yeah.
Okay. So this relationship to cardiac output is pretty important to understand. I was going to say something else about it. Man, one of the questions one of you asked, let me see if I regain my thought here. Okay, so we don't really talk a lot about afterload or resistance, but let's just say, oh, I know where I was going to go with this, okay? Coming back to my MI thing, you haven't talked about shock yet, okay? And you'll talk about shock, but we oftentimes associate shock with hypotension. Their blood pressure is low. They're below 90/60. But that's not true. Okay? The definition of cardiogenic shock, and you'll get to this in your shock lecture, is actually tachycardia with tachypnea. So let's just say that this patient's this heart rate was 118, and they were breathing 22 times a minute. And then after I gave my nitroglycerin and affected preload, their heart rate went up to 128, and now they're breathing 32 times a minute. Their blood pressure may be normal, but they are now in cardiogenic shock, early cardiogenic shock. Okay? And I certainly wouldn't give the patient, even if the blood pressure was normal, responsive, I would not give any more nitro. As a matter of fact, nitroglycerin should be contraindicated in tachycardia. If you see tachycardia, nitroglycerin should not even be a consideration. Okay, and it's like that in many protocols, maybe even in your book as a contraindication. Okay, and that's why. That's why. Okay, all right. What if I have a patient who has a septic shock and their blood pressure is low? Okay, so sepsis affects the container, makes the container dilate. Okay, so the heart's okay. So of my cardiac output, my heart rate's elevated because stroke volume's down. Why is my stroke volume down in septic shock?
Your preload volume is.
Okay, preload volume and
Sepsis is afterload. Ain't that an infection?
total body infection.
So it's going to affect your contractility, the pump, because of the muscle, right?
Potentially yes. Potentially yes. Good point. But I'm getting to the container because it dilates the container. And if I dilate the container, what does that do to number one and number two?
Resistance goes down.
Yeah, because the arterial side goes like this and the venous side goes like this. Okay? So these are patients that we give them a lot of volume, they'll get a lot of fluid to improve the preload side, and then they'll also be on medications like norepinephrine, Levothed, neosynephrine, maybe dopamine, whatever, to improve the arterial side to shrink it down. They'll use combo therapies for that. I only tell you that so that you can see the relationship to this. Okay? If we add volume to the volume side, and if we can improve afterload or resistance by shrinking the container down, then we improve cardiac output. All right? So if there's a concept that you can really apply in your mind and come back, especially as you're going through medical emergencies and how do they manage sepsis and cardiogenic shock and anaphylaxis and all those things, come back to this because this is the very basic principle of it. And so much in medicine, when it comes to critical care medicine, is based off of this, right here. Okay? All right, so the next thing we're going to talk about is a little introductory, and then we're going to go to lunch about cardiac cells. Now, cardiac cells are pretty cool. All right, cardiac cells are pretty cool. They have some inherent abilities of their own that are unlike any other cells. First of all, a cardiac cell, muscle cell, Is that vibrating to you guys too?
Mm.
Well, I don't know if I'm gonna be able to look at that. Tolerable back here.
We should have said no.
Do what?
We should have said no, it's like, no, it looks fine with us.
Yeah. No, I don't see that. Reggie, you should have been on top of that. You should have been like, no, it's fine. All right. So, first characteristic is they're excitable. And I know you guys are